So they are embryonic cells which have not involuted completely. Is this clear? So that is the reason why germ cell tumor can arise from the brain. Is this clear?
Yes. Thank you.
Right. So where were we? Right. Can you see my screen?
Yes.
Okay. So we finished with the microscopic features of Alzheimer's disease. Now regarding the clinical course. So in clinical course, as we have discussed, the disease starts gradually. So first it will start with the loss of memory, forgetfulness, and then as the disease progresses, so the patient will develop severe neurological deficit. So first it starts from the temporal lobe, then involve the frontal lobe. So when frontal lobe is involved, so in frontal lobe we have the very important functions like the cognitive abilities, like the intellectual functions, like the performance of the mathematical skill, then some fine motor movements. So all these functions they will be lost gradually, and as the disease progresses, when the involvement of the parietal lobe and also the other lobes, so the patient will uh, like even he will not be able to communicate, he will become mute, and in the advanced stage of the disease the patient will be like he's not aware of his surrounding, he's just lying on the bed, he's bedridden, and the family members they have to take care of him. And the terminal event is because of, in most of this patient is because of, so the patient will not die because of dementia, patient will not die because of atrophy of the brain, but the patient will die because of pneumonia, severe lung infection. Right. So this was all about Alzheimer disease. Now the next is Parkinsonism. Now if you recall, we have seen what is the meaning of Parkinsonism and what is the meaning of Parkinson disease. So Parkinsonism is a clinical manifestation, clinical syndrome, which includes diminished facial expression, stoop posture, bradykinesia, fascinating gait, rigidity, the lead pipe rigidity or the cogwheel rigidity, and the pill rolling tremors. And if you recall my lecture at that time, I have shown you how what is the appearance of the patient of Parkinsonism. And what is the reason for Parkinsonism? It is because of the damage to the nigrostriatal pathway, particularly the damage to the substantia nigra. Now, if the damage is because of neurodegeneration, because of the deposition of abnormal protein, then Parkinsonism will be called as Parkinson disease. So in Parkinson disease, the Parkinsonism is usually L-DOPA responsive. So if you give L-DOPA, the clinical manifestations will improve. And the epidemiology of Parkinson disease is same like the Alzheimer disease. The disease usually starts after the age of 50 years, gradually progressive disease, relentless disease, it will not stop. And majority of the patients cases they are sporadic, and maybe around 5 to 10% of cases they may be familial. So again, there is a role of some genetic abnormality. Then next, there are certain risk factors. Like it has been found that the people who are exposed to pesticide exposure increases the risk for Parkinson disease. And caffeine and nicotine, they are some of the studies they say it is protective in nature. Right. Now regarding the morphology, so this is the slice of the midbrain, and here you can see the substantia nigra. So substantia nigra it appears black in color. So the reason is why it is black in color. It is because of the melanin pigment, and because of neurodegeneration, since there is loss of neuron, it means there is also loss of melanin. So in the lower part of the image, you see there is pallor in the region of the substantia nigra because of the loss of the neuron. And if you take a slice section and see under microscope, so in the microscope we'll find a very important finding. So the remaining neurons, the neurons which have still not degenerated, which are alive, so you may find a round structure, round body inside the neuron, which is called as Levy body. Levy body was discovered by a scientist called Levy, so that's why Levy body. It's a round body, and if you look carefully in this patient, in this neuron, it's a single body, but it can be even multiple. And it is located in the cytoplasm, so it is cytoplasmic. And if you look carefully in the center, it has a dark zone surrounded by a light halo, light zone. So this is the description of the Levy body. And if you look at the protein structure of the Levy body, it is composed of alpha synuclein. The name of the protein is alpha synuclein. So this is the abnormal protein which gets deposited, and it's an indigestible protein. And this is typically seen in four important locations. So you should at least remember the name of the first two sites: substantia nigra and locus ceruleus. The other two sites are the basal nucleus of Maynard and the dorsal motor nucleus of the vagus nerve. So these are the four important sites. So this was all about neurodegenerative diseases. So any query, any doubt with respect to demyelinating and neurodegenerative diseases?
No.
The next topic is the cerebrovascular diseases. Right. So can you see my screen? Cerebrovascular diseases.
No, not the slide.
Right. Now can you see?
Yes.
Yes, doctor.
Okay. Right. So the definition of cerebrovascular disease is very straightforward. It's the pathology of the brain, the abnormality of the brain because of some abnormality or pathology of the cerebral blood vessel. Now, why we need to study this condition is because it is the third most important reason for morbidity and mortality in almost all the countries of the world, and it leads to most what you can say, it is the most prevalent neurological disorder, and it is one of the most important reasons for neurological deficit. So if any patient is presenting with neurological deficit, there is high chances it is because of cerebrovascular disease. And a general term which is used for cerebrovascular disease is called as stroke. But stroke is a layman term, so you should avoid using this term stroke, because every person they know what is meaning of stroke. But as a medical student, you should say cerebrovascular disease or you should say cerebrovascular accident. So these are the two medical terms. And the third term also can be used is stroke. So a patient of stroke will present with neurological deficit. Now, how do we classify cerebrovascular disease? So if you remember, we classify into two broad categories. In one category, uh, we include hypoxia, ischemia, and infarction. And in the next category is the hemorrhage. Now, if you look at hypoxia, ischemia, and infarction, basically it forms a part of a spectrum. So hypoxia and ischemia is one end of the spectrum, and infarction is the severe end of the spectrum. So hypoxia ischemia is a mild condition, and its severe condition is the infarction. So in hypoxia and ischemia, there is just decreased blood flow. But in infarction, there is total obstruction to the blood flow. So infarction is more severe as compared to hypoxia and ischemia. So they form a part of a spectrum. And in some patient, the disease will start in the form of hypoxia ischemia and it will end with infarction. Sorry, I will connect my laptop. The battery is going down. Right. So first we'll start with hypoxia ischemia infarction, and we have seen what is the reason why hypoxia and ischemia is so important with respect to brain, because the brain or the neurons, they are highly dependent on oxygen. They are highly aerobic tissue. It means they are sensitive to hypoxia as compared to other tissues, other organs of the body. All the metabolic functions of neuron is highly dependent on oxygen. So even if they if they are affected by hypoxia for a very short duration of time, so it will cause more effect on neurons. So they will have more damaging effect on the neurons. So that's why hypoxia is very important with respect to brain as compared to other organs. So even if you go to high altitude, so even in the high altitude, the patient will experience hypoxia and he may feel dizzy. So basically, dizziness is again a small, it's a very mild type of neurological deficit. Right. So now we classify hypoxia, since hypoxia and ischemia they are closely related to each other. We cannot separate it, because when there is ischemia, it will also lead to hypoxia. So sometimes it becomes very difficult to separate hypoxia and ischemia. So we club it together. So we call it as hypoxic ischemic encephalopathy or hypoxic ischemic injury. So it can be either global, affecting entire brain, or it can be it can affect a small part of brain or local involvement. So when there is involvement of the entire brain, what are the reasons because of where the entire brain is involved? So when there is reduction to the blood flow to the entire brain, so this happens like for example in case of cardiac arrest or in case of shock or in case of severe hypotension. So it affects the entire brain. So when entire brain gets hypoxic or it suffers the effect of hypoxia or ischemia, what happens? The patient will lose consciousness. Patient will lose consciousness. And I have given you the example of cardiac arrest. If you can recall, at that time I have mentioned someone goes into cardiac arrest, and if you resuscitate, so you there will be reperfusion to the brain, and the patient will not like will develop a permanent neurological deficit, so the effect will be very mild. So in that situation the patient will just lose he will have a confusional state, he will lose the memory for that short duration of time, he will not recollect the events what happened to him. But if the hypoxia ischemia lasts for a long duration of time, for example if someone develops a cardiac arrest maybe in the bathroom or maybe in some another place where there is no one beside him, and there is hypoxia for a long duration of time, so the patient will suffer permanent neurological damage. So entire brain will get the neuron will get damage in the entire brain. So this will lead to a vegetative state. So the patient will land up in vegetative state. Now, when there is involvement of a small part of brain, like for example, if there is decreased blood flow, so it is called as focal cerebral ischemia, and if there is complete obstruction, it will lead to infarction. Now, this infarction. So, what are the reasons for infarction? So again, this is the same repetition of the general pathology as well as in the serious law. So the most important reason for infarction anywhere in the body, the two most important reason is the thrombosis superimposed on atherosclerosis, and the next is the embolism. So these are the two most common reason for infarction anywhere in the body: thrombosis superimposed on atherosclerosis and embolism. Now, what are the predisposing factors for thrombosis? Hypertension and diabetes mellitus. So other way around, patient of hypertension and diabetes mellitus, they have a higher incidence of thrombosis, which leads to neurological deficit or brain infarction. So what are the common site for thrombosis in the cerebral blood vessels? Number one, carotid bifurcation, origin of the middle cerebral artery, and the third is the either end of the basilar artery. The next important reason is embolism. Now, from which side the embolus may arise? Number one is from the heart. The most important reason for embolism is the cardiac thrombus inside the chamber. So it is called as mural thrombus. It becomes loose, it becomes embolus. Now, what causes thrombus inside the heart? So these are the predisposing factors: the myocardial infarction, valvular disease, atrial fibrillation. Is this clear? So in other words, patient of myocardial infarction has a higher frequency of developing brain infarction. Is this clear? So you have to correlate like this. Other reasons, other uncommon reasons are like, for example, vasculitis. Even vasculitis may cause brain infarct. Then paradoxical embolism seen in children suffering from atrial septal defect, ventricular septal defect. So the thrombus, the embolus from the venous side enters into the arterial side. So this is called as paradoxical embolism. Then after cardiac surgery, embolism after cardiac surgery, or the last one is the embolus arising from the bone marrow, which are called as fat emboli. These are tiny emboli. So this causes shower embolism, multiple tiny emboli. So these are usually seen in road traffic accident, crush injuries of the legs of the long bones. Now, what are the common sites for embolic infarction? Territory of distribution of middle cerebral artery. So middle cerebral artery is the most common cerebral artery which is affected by the embolism. Now, what is the reason why embolus is entering into middle? Why not anterior? Why not posterior? So the reason is the middle is in more in continuity with the internal carotid. So the first thing, the embolus will come in the internal carotid. From there, it will either go into anterior, middle, or posterior. So there is high chances that it goes into middle rather than anterior and posterior, because it is more in continuity with the internal carotid. And the equal in both these coagulable state. Then drug abuse. Again, drug abuse like amphetamines and cocaine. So if you read news or if you read newspaper or if you may find that like you hear news that some of the celebrities they have died after drug overdose. So what is the reason? What happens because of the drug overdose? So these are the reasons. So drug overdose will lead to sympathetic surge, and it will cause increased blood pressure and vasospasm. So vasospasm will lead to brain infarction, stroke, and sudden death. Now the infarct can be of two types, red infarct or the hemorrhagic infarct. So this is the slice showing the red infarct. So you can find petechial hemorrhages. So this is called as red infarct or hemorrhagic infarct. And the other type is the pale infarct or non-hemorrhagic infarct. So what is the reason for red infarct or hemorrhagic infarct? It is because of the embolism. So what happens, why there is red infarct with respect to embolism? So if you remember my lecture at a time, I have told you the reason. So what happens, some part of the embolus, it may get dissolved. So there is reperfusion. So this blood, it goes into the infarcted area. And since the infarcted area is already dead, so it just seep inside into the infarcted area. And another reason is there might be some blood coming from the collaterals. So this blood again enters into the infarcted area. So that's why that infarct area is hemorrhagic. So hemorrhagic infarct or red infarct. And the other infarct which is associated with thrombus is the pale infarct. So we need to differentiate this. And on MRI examination, you can differentiate which one is red infarct, hemorrhagic, which one is non-hemorrhagic infarct. And you have to decide the therapy based on the infarct. So in case of pale infarct or the non-hemorrhagic infarct, since it is because of thrombus, you can initiate thrombolytic therapy, and which is contraindicated in hemorrhagic infarct or the red infarct. Because if you give thrombolytic therapy in hemorrhagic infarct, which is because of embolism, so what will happen? More blood will enter into the infarcted area, and on the contrary, it will exacerbate, it will increase the infarct area, it will exacerbate the neurological deficit. So that's why it is contraindicated in embolic therapy, and it is recommended in for the thrombus. Now this is the old hill infarct. So here, see what happens after infarction, that area will become dead. So the macrophages. So what are the macrophages which are present in the brain? The microglial cells. So they will remove this infected area, and that area will be replaced by the gliosis. But we know gliosis, it cannot replace a large area. So some part of the brain will appear like an empty cavity. And if you look carefully inside, you see some whitish area. So basically, it is the area of gliosis. So this is old hill infarct. So this is a large infarct. Now, what are the microscopic features? So again, if you remember the CVS block, in CVS block, we have seen the microscopic changes seen in the myocardial infarct. So these are the microscopic changes which are seen in brain infarct. So early changes and late changes. So in the early changes, one of the initial feature which is seen, microscopic feature which is seen is the red neurons. Basically, these neurons, they don't become red. They are more eosinophilic. They are more pinkish. So they appear red. So they are called as red neurons. So the reason for redness is that because of the hypoxia, because of the ischemia, the neurons, they develop microvacuolization, small tiny vacuoles which are pinkish in color. So that's why they appear more pinkish, more reddish. So this is called as red neurons. So this is a sign that this neurons has suffered from hypoxia and from ischemia. Then later on, in the later stages, what happens in the subacute stage? The neurons, they will die. So there will be liquefactive necrosis. We know the necrosis which is seen in the brain is called as liquefactive necrosis. So there will be, so this is the area. So this is the area showing liquefactive necrosis. So here, if you look carefully, so these are all macrophages, the microglial cells. So these macrophages, they are engulfing the dead necrotic tissue. They are removing the dead necrotic tissue. So there is influx of macrophages. And in the late stage, what will happen? The macrophages, they will remove everything. We know neurons cannot regenerate. So what happens? That area will be replaced by the gliosis, by the glial tissue, by the astrocytes. So here, if you look at this image, so this is the area showing gliosis. So if you look carefully, they are just small tiny dots. So these are the nuclei of astrocytes. The big nucleus is neuron. So you don't see any neuron here. So they are just the nuclei of astrocytes. And also look at the area. It is, you see some empty spaces, white spaces. So basically, it is abnormal. That's why it cannot become the normal brain substance. So that's why it is loose. The glial cells, they are just loosely present. So this is the area of glial cells. So this was all about the first category. Now the next category is the hemorrhage. So when we say hemorrhage, it means we are talking about the intracranial hemorrhage. Now intracranial hemorrhage can be of two types: spontaneous or non-traumatic and traumatic. So the name itself is self-explanatory. Non-traumatic means without any trauma. So it doesn't mean that there is no reason. There is reason, but the reason is intrinsic inside the vessel. In traumatic, the reason is extrinsic, something like there is an external injury. There is some external reason. So in spontaneous hemorrhage, we have two examples here: intracerebral or intraparenchymal hemorrhage and subarachnoid hemorrhage. And in traumatic, we have epidural above the dura, subdural below the dura, then intracerebral inside the brain, and subarachnoid below the arachnoid membrane. So if you look at the examples of spontaneous hemorrhage, the intracerebral and subarachnoid. So intracerebral and subarachnoid hemorrhage can be either because of spontaneous, non-traumatic, or it can be because of traumatic. Yes. Someone is asking some question or not?
No.
Okay. So first we will start with the non-traumatic hemorrhage. So in non-traumatic, one of the important example here is intracerebral or intraparenchymal hemorrhage. So usually seen in middle to late adult life, usually after the age of 60 years. And the reason for intracerebral hemorrhage is rupture of small, tiny intraparenchymal blood vessels. And what are the predisposing factors? Again, the most important predisposing factor is hypertension, high blood pressure. And the next is cerebral amyloid angiopathy. Now, how hypertension will cause rupture of the blood vessels? So there are multiple reasons. So hypertension will cause atherosclerosis. Hypertension will cause high vein arteriolosclerosis. Hypertension will cause direct necrosis. The high pressure inside the blood vessel will cause direct necrosis of the vessel wall. And the last, very important, is because of the high blood pressure, the tiny vessels inside the brain, they may develop aneurysm, which are called as Charcot-Bouchard microaneurysm. They are very, very tiny aneurysm. If you look at the size of the vessel, it is less than 300 micrometer, very, very tiny blood vessels. And they are usually seen in basal ganglia. So these microaneurysms, they may rupture and there will be bleeding. So what are the common sites? Putamen, thalamus, and pons. So if you know what are the functions of putamen, thalamus, and pons, then you can easily remember the neurological deficit. Or other way around, if you come across a patient with neurological deficit, from neurological deficit, you can get an idea which part of the brain is involved. So this is a slice of the brain showing a huge, see, look at the size. Look at this size. It's a large intracerebral hemorrhage or intraparenchymal hemorrhage. And it is present in the location of the basal ganglia near the internal capsule. All important vital, what you can say, they are passing through this area. And look at this image, massive. So this is massive hemorrhage, a very huge, very large blood clot. And if you look at the hemorrhage, it is present inside it is present in the substance of the brain, is intracerebral, as well as it is involving the ventricles. So it is intraventricular as well. And from the ventricles, it also involves the subarachnoid space. So it involves all the three spaces. So intracerebral, intraventricular, and subarachnoid as well. Now the next type is the subarachnoid hemorrhage. So subarachnoid hemorrhage, the most common reason for subarachnoid hemorrhage is a rupture of saccular or berry aneurysm. So at the time of lecture, I have told you an easy way to remember is S for saccular, S for subarachnoid. So S for subarachnoid, S for saccular aneurysm. So SS. So we should know all the details about saccular or berry aneurysm. So it is the most common type of aneurysm. It is usually present around the circle of Willis, in the circle of Willis, and look at the incidence. It is present in 2% of the world population. So if you do autopsy on 100 patients, you will find saccular or berry aneurysm in 2 patients. And in some patients, like almost 20 to 30% of patients, it might be multiple. And these aneurysms, they are called as saccular aneurysm, they are called as berry aneurysm, and they are also called as congenital aneurysm. So congenital aneurysm, this name congenital is a misnomer basically. It's not an actual name, but some of the books they still use this term, congenital or berry aneurysm. See, these aneurysms, they are not seen at birth, they are not present at birth, they develop in adult life. But the pathology which is responsible for this aneurysm is present since birth. So that's why the term congenital is a misnomer. So what is the reason for saccular aneurysm? The exact reason is unknown, maybe because of some genetic abnormality, and it has been found that there is a defect in tunica media. We know tunica media provides stability to the blood vessel. So if the tunica media is defective, what happens? It may lead to weakness of the vessel wall, formation of the aneurysm. And the two most important predisposing factors which may lead to aneurysm is cigarette smoking and hypertension. So this will promote formation of aneurysm. And again, we don't know the reason. The aneurysm, they are more frequent in females, and there is high chances that they will rupture in the females. So what are the common site? We know the common location is circle of Willis, but in circle of Willis, the three most common location is number one at the junction of anterior cerebral artery and anterior communicating artery. The next it is located in the middle cerebral artery, second most common location, and the third is the junction of the posterior communicating and the middle cerebral artery. So now pay attention to this. Middle cerebral artery has three important. Three important pathological correlations. Number one, middle cerebral artery is the second most frequently affected artery by the thrombosis. It is the most common artery which is affected by the embolism, and it is the second frequent site for secular aneurysm. Is this clear? So you can remember like this. So this is the actual image of the aneurysm. Look at the aneurysm. So from above, it appears like a berry. It appears, I hope you know strawberry, mulberry, blueberry. So from the above, it resembles like a berry. So it is also called as berry aneurysm. So secular like a sac. It is like a bag. So secular or a berry aneurysm. So this aneurysm in this image, it is located at the junction. It is located on junction of middle cerebral artery and posterior communicating artery. Now this aneurysm is bounded by a thin wall. It is a bounded by the thin wall because there is no tunica media here. So it is just tunica intima and a very thin amount of tunica adventitia. There is no tunica media. So it is very thin walled. And that's why, and since it is filled with blood, so you can easily see the blood inside. So it is translucent and it is bright reddish because of the blood. And what is the complication? The most dangerous complication of this aneurysm is since it is thin walled, so it can rupture easily, can rupture anytime. So this is the most dangerous complication. Other complications are it may develop atherosclerosis, calcification, or thrombotic occlusion. So these are the common complications which are seen in all the types of aneurysm, not only secular or berry, but almost all the types of aneurysm. So now we should know some details about the rupture of secular aneurysm. So how this aneurysm may rupture. So what are the reasons? So the rupture basically cannot be predicted when it will rupture, but it has been found that it commonly ruptures in females and usually ruptures after the age of fifth decade of life, after the age of 50 years. And it usually ruptures when it becomes more than 1 centimeter in size or 10 millimeter in size. And there are certain predisposing factors. Any condition which increases the intracranial pressure, like at the time of straining of stool or at the time of sexual orgasm. So this is the image showing subarachnoid. So this is the base of the brain, and here you can see the circle of Willis, and you can see the aneurysm. So a ruptured aneurysm, and here you can see the brownish blackish blood. So this is subarachnoid hemorrhage because of the ruptured secular aneurysm. Now, what is the clinical course? Because of the rupture, there will be subarachnoid hemorrhage. Patient will experience a very, very severe type of headache, very severe type of headache, and the patient will lose consciousness. And almost 50% of patients they will die because of the first rupture, and the rest who survives, again they have a higher chances of developing another rupture. With another rupture, again other patients or many number of patients they will die. So with each rupture, the prognosis goes on decreasing. Now this is the list of other types of intracranial aneurysm. 2 or 3 we have already discussed: secular aneurysm, Charcot-Bouchard aneurysm, atherosclerotic aneurysm. Then if you recall, we have already discussed mycotic aneurysm, traumatic aneurysm, dissecting aneurysm in serious bone. Now the next type of hemorrhage are the traumatic hemorrhage. So as the name suggests, it is because of some external injury, external trauma. So one of the important example here is epidural hemorrhage above the dura. And the reason for this hemorrhage is rupture of middle meningeal artery. Rupture of middle meningeal artery. And what is the reason for rupture of middle meningeal artery? We know the middle meningeal artery, it passes below the pterion. Pterion, it is the weakest part of the skull bone. So it is located around the temporal bone. So any injury, any trauma to the temporal bone, any fracture of the temporal bone will cause rupture of the middle meningeal artery, and this will lead to epidural hemorrhage. It is commonly seen because of trauma. So this is the image showing the epidural hematoma. On the left side, see here you can see the whitish dura, and this is the hemorrhage which is present above the dura, epidural hematoma. and it shows a very typical clinical manifestation which is called as lucid interval. So the example of this has been seen in like football players. So like for example, a player is playing and he gets hit on the temporal lobe of the the temporal bone of the skull, and because of the fracture, there will be rupture of the middle meningeal artery. There will be bleeding. Because of the bleeding, the patient will lose consciousness. He will collapse on the field. And what happens after some time? The middle meningeal artery will go into spasm, so the blood flow will stop. And after some time, this player, he will regain his consciousness and he will say, "No, okay, I'm fine. I can play." So now again he's playing football, or he's doing some other activity, and after some time the spasm of the middle meningeal artery will go away. There will be another bleeding, and this bleeding will cause another episode of loss of consciousness. So the the regaining of consciousness between the two episodes of loss of consciousness is called as lucid interval. Is called as lucid. So very typical feature which is seen in uh, uh, epidural hemorrhage. Now, this condition is a neurosurgical emergency, and you have to urgently decompress the skull, because it will cause increased intracranial pressure, which may lead to herniation of the brainstem, and the patient will die because of this. So, it is a neurosurgical emergency. So, an urgent hole has to be drilled into the skull to decompress the pressure from the skull. Now, the next type is the subdural hematoma. So, the reason for subdural hematoma, it means the bleeding below the dura. So this is the image. This is the image showing the subdural hematoma. And on the left side of the image, here you can see the dura, and you can see the whitish membrane, that is the arachnoid membrane. So this is the subdural space. And the reason for subdural hematoma is rupture of the bridging veins. So here you can see the bridging veins. So these are the bridging veins. So what are bridging veins? Bridging veins, these are the veins which runs over the convexity of the brain, and they pass through the dura. So basically they pass through the subdural space and they enter the dura and they enter dural sinuses. So now in case of old age, in patient of old age, in very old individuals, in senile individuals, like after the age of 80, 85 years, and also in patient of Alzheimer's disease, what happens? There is generalized atrophy of the brain. So the brain gets atrophied. Now because of the atrophy of the brain, these veins, they get stretched up. And also in the old age, the veins, they become more fragile. So even with the minor head trauma, these veins, they may rupture easily, leading to bleeding. So this causes subdural hematoma or subdural bleeding. Another example here is it is called as shaken baby syndrome. So it is usually seen in child abuse. So it has medical legal significance. It's called as shaken baby syndrome. So violent shaking of the head of the child may cause a displacement of the skull bone, and this displacement of the skull bone may cause either rupture of the middle meningeal artery, or it may also cause rupture of the bridging veins. So it may lead to both. It may lead to either epidural hemorrhage or it may lead to subdural hemorrhage. So shaken baby syndrome again is a medical legal what you can say, it has medical legal significance, and it may lead to subdural hemorrhage, as well as it may lead to epidural hemorrhage. So these are the two important examples here. Right. Any query, any doubt? Am I clear?
Doctor,
Yes.
in subarachnoid hemorrhage, which artery is the most affected?
You tell me, what is the reason for subarachnoid hemorrhage?
What? Excuse me? Can you repeat the
What is the
question?
reason for subarachnoid hemorrhage? What is the reason for subarachnoid hemorrhage?
A saccular aneurysm.
Hmm?
Saccular aneurysm.
Saccular aneurysm is the reason, or rupture of saccular aneurysm is the reason?
Rupture of saccular aneurysm.
Right. So you got your answer. I hope you understand the meaning of aneurysm. I hope you understand the meaning of aneurysm. I hope you understand the meaning of aneurysm.
Okay.
Can you tell me what is the meaning of aneurysm?
I don't know.
You don't know?
No.
So this is a very basic thing. Can anyone tell what is the meaning of aneurysm? What is the definition of aneurysm? Yes, which leads. Yes, which leads to
Swelling?
bulging or the
Yeah.
right
The
or the widening. Yeah, right.
rupture.
Yes. So that is called as aneurysm. So the rupture of sacral aneurysm will lead to, or it will lead to subarachnoid hemorrhage. So that is the most common reason for subarachnoid hemorrhage. And what is the most common site for sacral aneurysm?
Carotid artery.
Anterior
Circle-
to anterior
of
junction.
Junction of, yes. So junction of anterior and anterior. Right.
Okay.
Any other doubt? Any other query?
No, thank you, doctor.
Thank you, doctor.
Thank you,
So
doctor.
should I close the meeting?
Yes, doctor. Thank you.
No, it's up to you.
Thank you,
tell me.
doctor.
If you want, I will sit like this. So if you have any doubt, any query, you can contact me on WhatsApp.
Thank you.
Okay.
Thank you,
Okay.
doctor. Thank you for your time.
Okay. Thank you.